Good morning, doctor. I'm here because I don't want to wear glasses or contact lenses any longer, and I want to learn about LASIK and PRK.
Great, it's nice to meet you, Mr. Nelson. Let's get started. My name is Brittany Bowman, and I'm an optometry resident at Georgia Eye Partners specializing in cornea, contact lenses, and surgical management, including the highlight of this presentation, refractive surgeries. Let's dive into this case and help the patient be glasses and contact lenses free. So this is a case of a 28-year-old male. Ocular history is significant for myopia and dry eyes. One important first question I ask is, what is the refractive error? Well, the refractive error for this patient is myopia, and in fact, high myopia. Next question I want to answer is, how stable is this refractive error? And we can see that over the past 3 years, the refractive error has been stable in both eyes. Now, refractive error does not paint the entire picture as to whether or not a patient may be a candidate for LASIK or PRK. Two more important additional tests are pachymetry and topography. So for pachymetry, the right eye corneal thickness was 559 microns, and for the left eye, 565 microns. And also topography revealed that both eyes had no irregular astigmatism and no corneal ectasia.
Now that the testing is over, do you think that I can get LASIK or PRK?
Let me look into some of these numbers and then I'll get back to you. For both PRK and LASIK, surgeons have a minimum residual stromal bed, which they prefer to be left following ablation. Most surgeons prefer between 250 and 350. So how do we calculate if someone will have a large enough stromal residual bed following LASIK or PRK? Here are two equations, but it is important to note that the flap thickness may be more or less depending on the surgeon, along with the microns ablated per diopter of myopia. So here are the rough residual stromal bed thickness values for both the right eye and the left eye, LASIK and PRK. So do these values meet the criteria? So right eye LASIK does not, and left eye LASIK does not, and maybe right eye PRK qualifies, and maybe left eye PRK qualifies. So overall, it appears like the patient is certainly not a candidate for LASIK. And at this point, there is no clear-cut answer as to whether or not the patient is a candidate for PRK. So what do we do? Well, Mr. Nelson, have you heard of ICL?
No, I have not.
Let's talk about ICL. So ICL is a posterior chamber phakic intraocular lens meant to correct refractive error. You can see it placed in the posterior chamber in the bottom image. And the ICL used in this case is EVO, which has aperture, so no LPI is needed prior to surgery. The contraindications include an anterior depth chamber less than 3 millimeters, decreased endocell count, and also narrow angles. None of these apply to our patient. Studies show that vision following EVO ICL remains at 20/20 or 20/25 uncorrected for the majority of cases. So there are many advantages of ICL, including less higher order aberrations compared to laser-based refractive surgeries. However, like most ocular surgeries, there are potential risks and complications. So Mr. Nelson, what do you think?
Sign me up, please. TZVEC. My life has changed. I can't believe it. I've always wanted. Thank you.
You are doing great, and I'm so happy for you. Let's take a look and see how the lens is doing. So all slit lamp findings were to be expected for 1 day post-op. However, one extra measurement we need is the lens volt, which is easily calculated with anterior segment OCT. So here is the lens, here is the ICL, and the distance between the two is the volt. We can see that this volt is in the acceptable range. Also, there were no surgical complications, and vision also remained at 20/20 at all post-op visits. So prior to ICL, there were limitations as to who can receive refractive surgery. Now, with the new technology of ICL, we can impact more patients' lives, and I really look forward to co-managing more surgical cases such as this one.